Good morning, friends. After the UIT session, Dr. Vishwas, now we are again back to the cataract session. The session is on unveiling the approach in complicated cataract surgery, where we are going to cover the how to manage a good complicated cataract. We have the faculty Dr. Rajesh Joshi from Nagpur, Dr. Ashok Shroff from Navsari, Dr. Vijay Nichlani from Bhopal, Dr. Urvija Chaudhary from Indore, myself, Dr. Chaudhary, and Dr. Harbans, our past president, and Dr. Maipal. I request Dr. Joshi to start the session with this topic on he will be speaking on astigmatism, how to give a best result. I request Dr. Ashok Shroff to take the chair. One of us can sit here. So, Dr. Vijay Nichlani. Yes, Rajesh, please.
Yeah, good morning, everyone. At the outset, I thank Dr. Rajiv Chaudhary, sir, and his team for giving me this opportunity to speak on astigmatism, how to give best results. I have no financial interest to disclose. If you see the cataract patients who are coming for surgery, almost 22% of your patient will have astigmatism of exceeding 1.5 diopter. And if you see the clinical significant astigmatism, which is around more than 1 diopter. Now, how do we correct this astigmatism? There are various ways to correct astigmatism. Spectacular contact lenses, which may be given post-operatively. Excimer laser, which can be used if you have some amount of post-op astigmatism by LASIK or PRK. Incisional corneal surgery, that is LRI, or astigmatic keratectomy at the time of the surgery, but they have their inherent problems. So the best way to correct astigmatism is by toric IOL, which can be corrected on the table itself, and the amount of astigmatism which you can correct is variable. It varies from 0.75 to maybe around 5 to 6 diopter. But the patient selection is very important. Patient should have primary corneal type of astigmatism, not the lenticular or other type of astigmatism. It should be regular bow tie type of astigmatism. Keratoconus with no or negligible progression. There should not be any progression in keratoconus. Post-keratoplasty, eyes only with mild to moderate amount of astigmatism. Patients with corneal pathology like Fuchs endothelial dystrophy or stomal dystrophy, they are not ideal for correction of astigmatism by toric lenses. Patients with potential capsular bag instability, that is pseudoexploration or zonal dehiscence, they are not contraindicated for putting toric IOL intraoperatively. So we have seen the indications and amount of astigmatism which you can correct. Now, what is different you can do intraoperatively? The accurate keratometry, that is very important. Reference and axis marking, that is different from your routine cataract surgery. And aligning of the IOL, which is very important. I will be dealing with this aligning of the IOL, because that is the most important step while you align the toric IOL, removal of complete OVD and the typing of the IOL. So we will see these 4 things one by one. Accurate keratometry readings, it should be comparable, consistent and repeatable. My choice of measuring the corneal dioptric power is by optical biometer. And if you have any doubt about the readings, you can perform topography. When you should repeat the keratometry, if you have K reading of less than 40 diopter or more than 47 diopter, because they suggest that if you have a less than 40 diopter of the astigmatism, that our keratometry reading, that suggests that the patient had previously undergone keratorefractive surgery. If it is more than 47 diopter, it suggests that some amount of keratoconus, so you have to cautiously deal with these patients. If you have calculated the keratometric reading on your spectacle correction that is not correlating with your optical biometer readings, you should Again, check with other methods. Difference in keratometric value between two eyes, that is, if you have a difference of 1 to 1.5 diopter in between two eyes, which is not correlating, so you should repeat the keratometry readings. Reference marking, there are various ways to mark the axis. These are the various markers which are there, and I'm not using any one of these because I had bubble marker, but because of ignorance of my staff, they put it in autoclave, and so it's no more available for measurement or marking of the axis. So the one which I use, which is suitable for measurement, is by reference marking on the slit lamp. You have everyone has slit lamp, and it has got an axis which it has got a slit beam which you can rotate horizontally as well as vertically as well as obliquely. So that is the best thing I think which you can do on the slit lamp. 0 to 180 degree or 90 degree you can mark on the slit lamp, and you can either mark with the help of your Jensen violet ink marker or with the help of 26 gauge needle. But 26 gauge needle puts permanent mark on the cornea, and that may give some amount of discomfort post-operatively. Maybe it will take around 24 to 48 hours to fade these marks. Now, limitations of manual marking: error of 2 to 10 degree, which is expected. Marks may fade or spread if you before you take the patient for the surgery. Difficult to see these marks intraoperatively. Image-guided systems are devised, but they are costly, and I don't have any experience about this image-guided system. As far as IOL power calculation is concerned, I totally rely on either optical biometer or on immersion, no contact method I perform nowadays. Intraoperative steps: incision should be placed at an intended axis, that is corneal or scleral. The perfect CCC in the tune of 5.5 millimeter, that is essential, so that there won't be any rotation of the IOL. No posterior capsular rent. If you have a posterior capsular rent, defer putting any type of premium IOL. May it be multifocal or toric IOL. Perfect cortical cleanup and perfect viscoelastic removal, that is very important. Now, if you see the alignment of these toric markers, every 1 degree of misalignment gives to 3.3% variability in the cylindrical power, and that is lost. So for 10 degree, there is 33% of the lost, and misalignment of 30 degree of IOL will lose entire cylindrical power. If you see the toric marks on the IOL marks on the toric IOL represent the flat curvature of the IOL to be matched on the steep meridian of the cornea. So you have to consider the steep meridian for placing this toric marks on the IOL. These are the various markers which you can place on the cornea for the placement of toric IOL. On the left side, you can see the marks which are there, and these are from 0 to 180 degree. And on the right side, you see the marker which you have to place on the intended axis to be placed while performing the placement of toric IOL. Now I will be showing this video of placement of the toric IOL inside. Once you have completed the cataract surgery, you can see I have placed marks on the toric IOL which is around 20 degree away from the intended axis on the cornea to be placed. I am clearing the viscoelastic thoroughly from the anterior chamber with the help of bimanual irrigation and aspiration. You can use whatever irrigation aspiration method you are following, maybe a coaxial or with the help of Simcoe's cannula, but I prefer this eye method because you can go behind the IOL and clean up the viscoelastic very properly. This cleaning of viscoelastic from behind the IOL is important because it can cause rotation of the IOL post-operatively. So place the irrigating cannula above the IOL and with the help of aspiration, you may not aspirate, just keep it behind the IOL and wash the viscoelastic. You can reverse the way you want. There may be refractive surprises after toric IOL. There are various reasons for it, and you can fix up this misalignment with the help of astigmaticfix.com, which is available on the ascrs.com. So take-home message is astigmatism correction with the toric IOL is more safe, effective, and stable, and which is predictable. And you should have accurate keratometry, reference marking, and accurate alignment. That is very important. Complete overlap of the optic axis by CCC and complete removal of the viscoelastic. That is the most important part. Thanks for your patience listening.
Thank you, Rajesh, for nice presentation on astigmatism management. We will take question answer after the full event. Now I request Dr. Ashok Shroff from Navsari to deal on the hard and white cataract, mature cataract.
Good morning, everybody, and thank you very much, Dr. Rajiv Chaudhary, for having me invited for this course and this presentation. I'll be covering this mature and hard cataract management, and there is something very specific about it. We do not have any financial interest in this presentation. The mature cataract is a morphological diagnosis where the cortex, sometimes it swells up so that the AC becomes shallow. At that time, at May, intralenticular pressure may go high, and the nucleus may be small, may be soft, or at times may be hard. There are risk factors before you proceed for the surgery. You must understand and you must keep in mind that because of the weak zonules and maybe in the old age, they look out for the phacodonasis on the slit lamp with dilated pupil. And then you must keep in mind that the capsule is going to be thin, friable, and therefore there may be risk of axis extension up to the periphery. And because of the high intralenticular pressure, then again the axis can extend. Of course, we know that here in these cases, the cortex would be very scanty. So you must keep certain points for consideration, that you make the axis carefully, you do hydrodissection carefully, at times you may not need, and then make sure that they rotate the nucleus very softly, careful. And when you do chopping, keep it horizontal. You do not go very deep or vertical. And in particularly such type of cataracts, you can keep the parameters high, the vacuum and the power. And more important, to save the corneal endothelial damage, you must inject visco frequently in the anterior chamber. We'll see this case here. This is a mature cataract. The rhexis is done. I must stain the rhexis, that is very also important. And make sure that if you, whatever little fluid you can inject, do the hydro, is okay, fine. And then see, this is because of the soft nature, the cracking is really easy, not that difficult. And once it is done, you can see, you can do a little further and make small segment. You can see that. And then it is brought out. Either you make the 4 segments first and then take out one by one, or you can do like this also. Say, and then sometimes the one half of the nucleus may not be easy to rotate, but then it comes out easily into the anterior chamber, and then should avoid phaco in the anterior chamber, go back a little bit and do the phaco and emulsify the nucleus. You can say the cortex is very less. You see very red glow. Now here is a very hard cataract. Very, very hard cataract. It's all fibers are very brown. Again, you can see that you have to stain the rhexis. And then see here, the moment I puncture the anterior capsule, the fluid has escaped. And then we must make sure that let this fluid go out of the anterior chamber. It's a debulking. And again, put the visco into the anterior chamber. And now it will be easy to do the rhexis. And less chances of getting extension to the periphery. But you must be very careful. We have to be very gentle, very polite, and very slow. And now, see, it's easy to rotate. Even without hydro, it's easy to rotate. It's very hard cataract. Now you can just watch here this power and the vacuum. They are less. Here is a Centurion machine. The procedure is 1, where the maximum power you can go up to 70, and the vacuum up to 250, 300. And now I put it goes to the, still we try. It's very difficult, you can see that. The emulsification is not that easy. Oh. And now you can see that the power has gone to 84, now 100. We are going to do procedure 3. Now it's easy to crack the nucleus. You can see that. Now again, it is in power, procedure 2, only 70 power, and vacuum is less. A little slow. You cannot emulsify easily. But the moment we'll switch over to the procedure 3, we'll raise the power. You can see that now. It has started coming fast. So this is very important, and probably it's now available, this type of facilities available with almost all type of phaco machines. But in such cases, you must keep the powers high. Otherwise, you have to go on doing the phaco in the anterior chamber. You can damage the corneal endothelium. And at one point of time, we have already injected viscoitis, has already gone back. We have skipped that part, but now you can see that. Very difficult. You have to maintain the chamber. This is very, very important. You have to maintain the chamber because the cortex is very less. So if the chamber becomes shallow, your tip may touch the posterior capsule and you can produce rent. See, the power is 100, the vacuum it goes to 500, and then it's easy. And make sure about the last fragments, you have to be very careful. If this go on moving and moving into the anterior chamber, see, now you can say that. There is hardly any cortex. When it is done, the lens is injected, cortex is cleared, and the lens is injected. You can see these patients on 3rd day. There are little mild keratitis here, very mild. But otherwise, you can see the iris structure. Even in spite of very hard cataract, if you take the precautions, your corneal, the keratitis is very less, very, very less. So, friends, what we should learn when we go home, debulking of interlenticular pressure by any method, whatever you like, but this is important. You keep the parameters high, particularly the power and the vacuum, and the more important is frequent injection of visco into the anterior chamber, and that too for good quality dispersive visco, not a just HPMC. Thank you very much.
Thank you, sir. Nicely covering a complicated, mature and hard cataract both together. We have come, there's so many sessions, we come with the mature cataract is different and hard and brown. Probably this is a combined mature brown cataract. Thank you, sir. Thank you, nice presentation. Now, I invite Dr. Urvija Chaudhary to speak on phaco in corneal opacity.
Thank you very much, sir, for this opportunity. Good morning, everyone. So here I'm to talk on cataract in corneal opacities. So it's a very commonly performed procedure, cataract, and it gives us very excellent results generally. But a pre-existing corneal opacity can pose a unique challenge here because of a limited visibility in visualizing the structures and increased risk of complications because of the damage to internal structures like capsule rupture and AIOS damage. It can also pose difficulty in IOL power calculations and placing the IOL in the right position. So here, most important is an appropriate preoperative workup along with surgeons' experience and patience to deliver us the optimal outcome. In assessing the patient preoperatively, the most important decision is assessing the extent of the visual loss due to cataract and corneal opacity. And a successful outcome can be achieved if you address the corneal opacity with minimum post-operative complications during the surgery. If opacity is very small, eccentric, it can generally be managed with simple cataract surgery. If it's a superficial opacity due to post-infection scar, trauma, or corneal degenerations and Salzmann nodular degenerations, we can do a sequential procedure by doing a PTK followed by a cataract surgery post 6 weeks or 8 weeks. And if it's a deeper opacity, it sometimes may need a keratoplasty, triple procedure. But with the keratoplasty, there comes a risk of graft rejection, infection, suture-related complications, and also scarcity of available donor corneas. So there are different ways we can deal and Alternatively, to a PK, we can deal the cataract surgery, like with increased red reflex, use of viscoelastics, use of intraoperative trypan blue, pupillary enlargement tricks like iris hooks and optical iridectomy, endoilluminations. Here is one video showing importance of a red reflex during the surgery. It was a post-PKP cataract where the illumination increased, the contrast increased because of the red reflex, and therefore the internal structures and other procedures could be dealt with properly due to the increased red reflex. Use of viscoelastics also increases the contrast and reduces the light scatter. One second. So reducing the light scatter provides better contrast and visibility of the structures, and therefore the procedure can be reduced, risk complications can be reduced. We can also use pupillary enlargement techniques. Here, the cornea was covered due to the overhanging bleb. So you have to do the procedure from the area which is optically clear and gives you a better view. So the surgery was planned temporarily, and because of semi-dilated pupil, iris hooks were used, which gave a better optical window. Iris hooks were placed inferiorly, and increasing the optical window provided a better visibility of the structures, and henceforth the surgery could be accomplished without any further complication. Here we can also do an optical iridectomy, sector iridectomy, which can provide an ambulatory vision to the patient post-operatively. Here it's a procedure with endo-illumination, where the illumination is reduced, the opacity is diffusely all over the cornea. So just controlling the illumination here increases a lot. So this is an endo-illuminator which was put in through a paracentesis. And with the help of this endo-illumination, all the procedures, all the steps were done successfully. Trypan blue also increases the contrast. So initially a trypan blue was injected, and then the endo-illuminator was inserted. Also important is your power modulations while performing the cataract surgery. IOP fluctuation should be minimal. Power modulation should be stagnant so as to reduce any injury to the corneal endothelium. Viscoelastics will increase the... use of viscoelastics will again increase the contrast. And coating the endothelium with dispersive viscoelastics provides the safety to the endothelium. So whole surgery was performed with the help of endo-illuminator, and post-operatively it gave a very good visual outcome to the patient, and not requiring keratoplasty for such patients. Then there can be cases where you have to go along with the keratoplasty only. Like this was, this was one patient with corneal dystrophy, stromal dystrophy. It spread all over the cornea and till a very deeper level. Even DALK was not possible because even endothelium was involved, a central opacity was seen. So a keratoplasty was planned along with cataract extraction, and trypan blue injected. Under open sky, the rhexis was accomplished, and with the help of a Sinskey hook, the nucleus was ejected out. Did not remove the complete cornea as to prevent any risk of expulsion. IL was inserted, and then the corneal procedure was performed. We can keep our donor graft ready, so to immediately and then the further irrigation, aspiration, and IOL positioning and everything can be done after placing the graft. This is one more procedure which was done along with the cataract and transplant, corneal transplant along with it. Here we did not need any nucleus dialing, and because of the back pressure, even after giving mannitol, the nucleus expulsed out immediately. We need to relax our eye speculum to prevent any unnecessary back pressure. This will help in preventing expulsion. And then the further grafting was done. We haven't placed the IOL yet. We wanted to put the graft first and prevent that back pressure. After placing 4 sutures, the IOL can be easily placed inside the bag. An irrigation, aspiration, cortical removal, everything was done after placing few sutures. So it's not always necessary to do a triple procedure. We can always plan a keratoplasty followed by cataract surgery after a few months for a better refractive correction that can be given to the patient. If we do it adjuvantly, then the refractive calculation of the IOL is very unpredictable. And there has been reports which shows that doing cataract procedure post keratoplasty after 4 to 6 months doesn't cause any extra endothelial loss and gives a better refractive correction to the patient. So we need to protect our endothelium in such cases by placing smaller incisions, use of viscoelastics, viscoadaptives, and keeping IOP low. And your the phaco should be done in bag to reduce any endothelial loss. IOL power calculation is also very unpredictable here, and we should make our patients understand that all IOLs are not made for all the eyes, and using multifocal IOLs is not a choice here. Refractive power calculation is again unpredictable using Barrett, True K, SRK, T formulas, and using tomography-assisted techniques also gives a better average readings and better IOL calculations here. And doing concurrent corneal treatments, like in cases of dry eyes, treating the dry eye first, in cases of degeneration, salzmanodular degeneration, or superficial opacity, if we treat that with PTK first and wait for a few weeks to perform cataract surgery, can give a very good refractory outcome to the patient. And the key here is we should always under-promise the patient so that they don't have over-expectations. Also, one way of doing the IOL power is doing a phakic retinoscopy. When you remove the IOL and remove the cataract, we can maybe try doing a retinoscopy if possible there on the spot and place the IOL. Post-operatively, we should take care of few things as to prevent any secondary glaucoma, IOP spikes, avoiding carbonic anhydrase inhibitors that can damage your already compromised endothelium, using hypertonic saline, NaCl 5% hypersol solutions. And we have to carefully monitor infections, inflammations, and graft rejections to ensure a very successful recovery of the patient. So I would, at the end, just want to say one thing, that cataract is a good opportunity to recover useful vision with, in many patients with a potentially poor outcome after a corneal graft surgery. So just giving a cataract surgery gives a good ambulatory vision, and not always a corneal graft surgery is required in such patients. Surgeon can benefit from endo-illumination techniques, optical iridectomy, iris enlargement techniques, capsular staining, and again, it's an alternative to grafting in such cases where the cataract can be managed without it also. Surgeon's experience and wisdom is very important here for optimal outcome. And in many such cases, if we prevent grafting, it saves a lot of time and subsequent complications for the patients. Thank you.
Thank you. Just one or two comments. I think now I'm not a corneal surgeon. Earlier I used to do. So because normally we take a graft larger than we cut the hole in there. So most of these cornea a little is steeper. So that means the IOL power required will be less in most of these cases than usually what a phakic will get. Secondly, in all the irregular corneas, whenever you are putting an IOL, refraction is very, very important. That means normally a standard guideline, a patient is aphakic, normal, a patient is normal, his power required is 20.5, 21. If patient is hyperopic, say after keratoplasty 4 or 5 diopter, that means this patient will need around 28, 29 diopter of a lens. If patient is myopic, he will need less than 21. So not only because the cornea is so irregular, of course you remove the stitches and try to stabilize the cornea. Even if you are putting in a toric IOL, it should not be placed on the basis of tomography, not on the basis of optical biometry, on the basis of the refraction of the patient if it is possible. So in a regular cornea, you need to take a refraction of the patient into the consideration before deciding for the what IOL to be used.
Sir, in
Thank
that
you.
case, do you think the IOL power calculation of the fellow eye would be little helpful? Fellow eye is normal.
It can, of course, all the whatever help you can take, you should take. But because over here the issue is not the length of the eyeball, but more of the cornea,
Because the cornea is changed now. So
So if
other
we
eye
are not doing the grafting, we need not take the other eye calculation. Only when we are doing the grafting, we can take the other eye calculation.
That will only, if you are not able to measure the axial length, if the cataract is too mature or something of that type. But so far as I have realized with the post-RK patients, all the regular cornea, refraction or the spectacles of the patients are very good guideline what IOL to be used. Very good guideline.
Thank you. Okay. Thank you, Dr. Urvija. Now
Thank you, sir.
I invite Dr. Raghav Malik. He will be speaking in place of the Dr. Maipal on the subluxated cataract.
Thank you, sir, for this opportunity. I'll present my talk on subluxated cataracts.
Raju, can I talk while it is being set?
Yes, sir.
Just a moment. See, in this case, when you use the fiber optic through the antechamber, make sure that you keep the scope light off. Because when the light of the scope, microscope is on, the lot of amount of light is reflected back from the corneal opacity. So your visualization will be very poor. And when you put the light source in the antechamber and the scope light is off, not 100%, but quite an amount of light will pass through the cornea, will go into your eye. And then the visibility is better. And one more thing, Urvija, I could have, one more very important, sometimes we do quite a few. The chandelier, use of chandelier light source through the pars plana. And then it gives you excellent visualization, red glow, and you can do. But after all, you should be very courageous to put the chandelier light source through the pars plana.
Thank you. Thank you, Dr. Shah. Now,
you, sir.
Dr. Raghav.
Okay, so I'll present my talk on subluxated cataracts. We know how complex a cataract surgery is when it is a subluxated lens. So the aim is always to preserve the capsular bag. We do have an option of secondary IOL, but we want to reserve that as a last resort. So our primary aim is to preserve the capsular bag and hopefully put a lens in the bag or in the sulcus if things do not work out. So this is, of course, what we look for in a subluxated cataract. We have to look for any obvious signs of subluxation, any phacodonesis, any increase of interlenticular space, or any extra space you see between the posterior edge of the iris and the lens. So these are some causes when you can have a subluxated cataract. Of course, it can be traumatic, which is very, very common. We do have Marfan syndrome, which we have seen very commonly. High myopia, uveitis, glaucoma, and pseudoexfoliation syndrome are some other causes where we do have subluxation seen. So the extent of subluxation, the grade of the cataract, and the etiology of subluxation, whether it is progressive in terms of a Marfan's or it is just non-progressive type of subluxation like in a trauma, will help us decide the type of cataract surgery and, of course, the type of device we can use. So just as a general rule, if we have a subluxation within 3 clock hours, just a CTR or a 3-piece IOL in the bag can help give us enough support for the bag complex. a 3 to 6 clock hour subluxation, which is non-progressive, a CTR and or a glued IOL or a ring fixation can help. And finally, for subluxations more than that, we have to go in for a glued IOL or a CTR or a ring segment. And ultimately, more than 210 degrees, a glued IOL is the only option we have. So the challenges, like I said, we face is, of course, difficulty in capsulorhexis because we know that there is no adequate zonular support. Once we have a subluxation, an obvious subluxation, very difficult to make a rhexis because you don't get the adequate counter traction. Excessive lens mobility, you can always have the risk of troubling more zonules and having more vitreous that comes into the anterior chamber. Also, if you have any vitreous herniation into the anterior chamber, if we go in for a phacoemulsification, we will always hydrate the vitreous, and hydrating the vitreous will cause more vitreous in the anterior chamber. Like I said, continuous vitreous hydration, that is always a complication, and that can always have your vitreous come into the phaco probe, and you'll keep taking up more vitreous. It becomes a continuous cascade, ultimately leading to any PVD, which can ultimately cause an RD. So how can we make this easier? Of course, femtolaser is one option, and of course, vitreous decompression. I'll discuss both. So this is a case that came to us, that was referred to us with a traumatic cataract. You can see on femtolaser that there is a traumatic pupillary damage. The advantage of the femto is that we can always, center the rhexis where the lens is. So once we have nucleotomy and a capsulorhexis, you can see the nucleus is there's some phacodonesis, and also the rhexis is free floating. There was some vitreous in the anterior chamber, which we could see on the femtolaser. Once we go in and remove the rhexis, then we go in and make the main ports, and we are using capsular hooks now. Why? Because we know there is an obvious subluxation, which is about 4 o'clock hours, and there is phacodonesis. So we go in, use the capsular hooks, and try and use 2 to 3 capsular hooks and support the bag complex. So once the capsular hooks are in place, we do a gentle hydrodissection. This is key. If you do a good hydrodissection, you will always have a mobile lens. Once the lens is mobile inside the bag, you can always rotate. If you don't have a mobile lens, you are going to cause more damage to the zonules. Then we go in, of course, it's a pre-chopped nucleus with the femtoseconds, so we can always go in and just do the nucleotomy and fragment the pieces and finish phacoemulsification. It is usually not so complicated once you have the stabilized bag. Once enough amount of nucleus has been removed, we will ultimately have to place a CTR. We go in, place an ECR. You can do this manually or you can use an injector. Once you put in the CTR, you're going to have some stabilization. This is the most critical part on how to put in the CTR. We can note some vitreous, which was expected because we saw vitreous in the anterior chamber. We'd go in, do a very gentle irrigation aspiration, and put in a 3-piece lens. We put in tricot, and we can see how the vitreous is herniating. So we go in, do a vitrectomy, anterior vitrectomy, and remove as much vitreous as possible. We're going behind the lens and doing more vitrectomy. Ultimately, this patient had a traumatic enlargement of the pupil, so we have to go in for a single pass photophotopupiloplasty also on table. We go in, we pass our needle, and we do 4 throws, and we try and recreate the pupil. Once we pass in the 4 throws, we can easily go in and recreate the pupils. This is going to, we just have to check again if there's any remnant vitreous tags. We put in an air bubble, and that ensures. The patient did very well. He was 6'9" on day 1, and we checked the retina also at 1 week. Everything was fine. So that is why the advantage of femtolaser, there is the rhexis is not dependent on zonules. So you can have a pre-rhexis, which is very comfortable. There is, of course, lens fragmentation, so lesser stress on zonules again. This is one more doctor case that came to us from Patna. The patient was 44 years old, roadside accident. He came in with a subluxation. Vision was 6'9", and 624 improved to 6'9". So we did a femtolaser with vitreous decompression. So this is the case preoperatively. I'll just show you the video. So if you see the femtolaser, you'll be able to observe that once we go in and do the nucleotomy, there is some vitreous already in the anterior chamber. So this is the area of vitreous herniation. So the advantage of the femtolaser is that the laser is going to penetrate through all this, so, and you will not have any challenge in going into the nucleus. So we do the steps of the femto laser. And this is the scan capsule. We can do a custom capsule, and we can center the rhexis on the subluxated lens. That's it. So we've centered the rhexis. We go ahead. And again, we start the cataract, and we can see there is an obvious subluxation and obvious vitreous herniation. So we go in, we make our ports. So the advantage of going in posteriorly from the pars plana is, of course, you mentioned chandeliers. That is, of course, one indication. But here, what we want to do is that because we know we are going to hydrate the vitreous, we want to go ahead and cut the vitreous from the base. If we do anterior vitrectomy during phacoemulsification, more and more hydration of vitreous occurs, and we are going to have more herniation in anterior chamber. So once we've cut the vitreous from the base, we remove the rhexis, and then we put a capsule before we start phaco, so that our lens bag is stabilized. Then we go ahead, do the cataract. The cataract was not very dense, as we did not expect it to be very hard. And once phaco is completed, we go ahead, do very gentle IA. It's going to be tricky because there is CTR in place. Then again, if you see, we've opened up the buckle, the plug from here, because we want the vitreous to come out from here and not from the main port. And once that happens, then we go ahead, put in 3-piece IOL. We go ahead, do more vitrectomy. That's it, close the case. Patient was 6'9" on day 1, all good. So this was the advantage. Basically, there is no more hydration of vitreous, and we can always come out with better. This is one more quick case. I'll show you a patient of Marfan's. You can see a gross subluxation. We go ahead, put dispersus viscoelasis, do a rhexis. This is pretty easy. It's a young patient, so we can go and do a rhexis. Once we complete the rhexis, we go and just with irrigation, we'll get the nucleus out. Then we put in a CTR. A CTR is not going to be enough, so we also have to put in a segment. So we put in a CTR and the segment, suture the segment through a tunnel, and you can see how well centered the bag lens complex is. And this is how the patient was on day 1. Good, very happy young girl, went home with a smile. So the take-home message, low fluid settings, because we don't want vitreous hydration. That is very important. Tamponate the area of zonal defect. Of course, we also have studies that use nuclear chunks to tamponate the area of subluxation. Flax reduces the risk of further complications. Vitreous decompression allows safe phaco, and capsular support devices give superior outcomes. So thank you.
Thank you, Raghav. Thank you for excellent consideration, and probably this is the real advantage of femto.
Yes, sir.
Making the rhexis.
Yes.
There was so many controversy whether femto is useful, not useful, hard, brown. But here it is the one
indication.
indication
Yes.
where the femto
Yes.
is, because it doesn't give the stress on the joint. Thank you, Raghav.
Thank you, sir.
I now invite Dr. Vijay Nichlani from Bhopal to speak on the phaco in traumatic cataract. इसके बाद और फिर last.
Okay. Thank you, Dr. Chaudhary, sir, for giving me an opportunity to share my thoughts regarding the traumatic cataract. I have taken few of the videos. This one, yes. So no financial interest? None? Traumatic cataract basically puts many challenges in the management of its cataract and putting the IOL implantation. Let us see what are those challenges and how we are going to manage them. It's a common sequelae of any ocular trauma, usually associated with many more ocular injuries, and it's a unilateral in young patients. This has been an observation. It could be a closed globe, it could be an open globe with a laceration, penetrating, perforation, globe rupture. So these are the complex situation we may come across with the traumatic cataract. The injuries could be penetrating, blunt trauma, electric shock, infrared radiation, ionizing radiations. These gives a different variety of the cataracts with the iridescence, opacities, stellate pattern, anterior capsular, posterior capsular, and the ruptures of the capsules as well. The pathophysiology of developing this traumatic cataract is very simple. With the trauma, the lens fibers are damaged. If capsule is opened up, there's an influx of aqueous fluid and hydration of lens fiber, and there's a formation of traumatic cataract. These are few of the challenges. It could be associated with the corneal tear, scar, injury to the iris, damage to the anterior posterior capsule, zonulosis, giving subluxation, dislocation, anterior segment inflammation, risk of developing glaucoma, vitreous prolapse, inflammation, retinal injuries. There could be a retained intraocular foreign body, and difficult IOL power calculation would be the challenge apart from endophthalmitis. The points to remember, pediatric age is very important because if we delay in management, it is going to develop amblyopia. Blunt trauma, very nicely covered the subluxation part. Angle recession is very important. In such cases, you need to check IOP, measure angle, and look for any secondary glaucoma. The management principle, the aim is just simple to get a good vision, proper history, anterior segment, posterior segment examination, X-ray, USG. You have to reduce the inflammation before going into the cataract surgery. If it is an intumescent ruptured anticapsule, the early surgery and early management is important. It is very likely that you should restore the vision immediately. Assess the injuries at the different levels. It could be a primary procedure when the capsule is opened up with the corneal tear and there's a intumescent cataract. It could be a secondary procedure whenever there's an intraocular foreign body, vitreous hemorrhage, and the RD management. Thereafter, you can go with the IOL implantation with the calculation. Visual restoration with different procedures, the phaco and SICS. Choice of IOL could be single piece, 3-piece, iris clip. It could be a procedure of glued IOL, Yamane, PMMA IOL. Depends upon the different situation, your expertise, and definitely what patient is going to pay you. It could be a primary or the secondary procedure. Difficulties, IOL power calculation, the management of associated pathologies. Vitreous management in these cases is very important. Complications, amblyopia, PCO, decentered IOL, residual refractive error, not getting enough vision because of other pathologies. Essentials in armamentarium in your OT, microsurgical instruments like vitreous forceps, vitreous Caesar, and the capsular access forceps. Vitrectomy unit, different variety of IOLs you must have with you. CTR rings, segments, Sioni rings, and the capsular retractors or the iris hooks. Now let us see, this is a traumatic cataract with a corneal involvement. The adherent glaucoma, ultimately I implanted an IOL and the iris laceration was seen. Let us see that what we do with this iris laceration. A very simple procedure of the suturing of this iris defect. This is a 26 gauge needle bent to go from this wound, and a needle with the suture is taken from the other end. You have to glide this needle to the 26 gauge needle, and both the loops from both the ends are out. Now you take a one loop, do a 4th row, pupilloplasty, and it is all done. So this is a repair of iris. Now let us see this case. It has got around 3 o'clock zonular weakness, and I could appreciate on slit lamp there was a vitreous as well. So the planning is just to keep your segment ready. So there's a scleral pouch here, and to support the capsule, I have taken the 2 incision, the axis. Since the anticapsule is fibrous, apart from the forceps, you many more times require to have scissors as well. Pass the iris hook, support the zonular weakness. This is very important. You need to remove the vitreous without irrigation. So whatever vitreous is lying in the anterior chamber in the periphery, will definitely will be cut, and there won't be any ingression of the vitreous from the posterior part. So once this is done, then irrigation, aspiration, softer cataract. These are usually traumatic cataract. I implanted 3-piece IOL supporting that gap. There was no vitreous, so there was no need of any segment support, and that part is closed up. Many more times you come across with this situation of partially absorbed cataract. So let us see what happens. You get this kind of plaque at the end of a surgery attached with the posterior capsule. You need to remove to give a good visual acuity to the patient to make this the visual axis clear. You can have a microsurgical instruments, and then you can take a help of capsular axis needle as well, and thereafter you can refashion or make the posterior capsular opening circular, implant IOL, and can do the optic capture as well to give a good centration of the IOL. Whenever you get any corneal laceration or penetrating injury, it is always mandatory to make the corneal suture first, so that whatever you are doing inside the anterior chamber, it has to be closed chamber surgery. So this was the thing, and IOL was implanted. One can implant toric IOL in such cases of trauma, having traumatic cataract. Alignment already have been discussed. I'll just take 1 minute more if you can allow me, sir.
Faster.
This is a very interesting case. Patient had a history of trauma, but nothing was seen on slit lamp examination, but one can see there was a little loosening of the posterior capsule. I tried to inject CTR from one side, and this is the CTR here, but still the bag was dialyzed. I tried from the other side, the bag again dialyzed. Ultimately, the bag was removed, and the retrofixation of iris clip IOL was done. The same way, nothing was seen on slit lamp examination, but when a viscoelastic is injected, there was more than 180 degree of zonular weakness. This was supported with the iris hook, but unfortunately, while doing irrigation aspiration, there was a small posterior capsular rent. Otherwise, I was planning to have 2 of the Sione rings. Here, you can see this was the thing. And later on, vitrectomy was done, and the iris clip IOL was implanted. Thank you, sir.
Thank you, Vijay, for excellent presentation in traumatic. It is really different. Now I invite Dr. Harbans to speak on the small pupil. Mic on.
Hello? Hello? So I'll be talking about the small pupil and how to handle it. So we know if the pupil is small, we have got many options. Some of them are like chemical. Now the phenocaine is available, and I have been using Gylocart, the one they use for the heart without preservative-free Gylocaine, along with the epinephrine diluted for dilatation of all my patients. Then we have got the viscoelastic, which stays in the eye for very long and stretches the pupil. If you use the product like Hilonjivi, it will stretch it more and you can do the rhexis. But when you are doing the phacoemulsification, Hilonjivi will get sucked very fast, so it is useless at that time. At that time, you need the viscoat, which will keep it pressed afterwards. And we used to do the stitching, but that is absolutely wrong way of doing the things, because there is an uncontrolled tear. And if you need to do at all, if you don't want to use anything, Then you can do micro-sphincterotomy. Take a Warner scissor and cut at a small 7-8 cuts. Each cut has to be less than half millimeter, 400 micron. But this can be done only in a rigid pupil. If there is a pupil is floppy, this will actually accentuate the problem. So in an aged patient where the pupil is tough, hard, not floppy and shaggy, if you do the cutting of the floppy, it will become more floppy. So don't cut them. And then of course the iris hook is the commonest used in India. But the better devices are tire and rim type of devices, where you put on a tire on the rim, you put something which holds the pupil around dilated 6 millimeter. Most common out of them is the Malugin ring which we use, or the Bhattacharya ring, which is very economical. Malugin is little expensive. It is costing around 10,000 rupees. Earlier Malugin rings were excellent. I could use the single ring for 20 times, 30 times, it never used to go bad. So now they made the material very soft, hardly you can use it 1 or 2 or 3 times. So they have actually decreased the strength of this ring. So Bhattacharya ring is a good option, costing less than 2,000 rupees. So I'll show you that it is possible to do phacoemulsification even in a small pupil without using anything. Now we do the rhexis, chop the nucleus, but one thing is very important, that do everything in the central zone. And what I'm trying to do over here is I'm trying to do from the periphery which has come out. And in fact, I prefer to take out the epinucleus when before the nucleus. But I don't want the epinucleus to drop back and nothing to hold back upon. So when the periphery of the nucleus collapses, I'll hold to the epinucleus and suck out the epinucleus so that the nucleus remains in the center. And once this nucleus is removed, IA, coaxial IA you cannot do in these cases, will be very, very difficult to remove. So the bimanual, so I'm using this irrigation port to stress the iris. But now I think Dr. Kumar has devised a very good irrigation cannula with the V in front of it to push the iris away. So that can be used. And then of course I always do hydroimplantation, no viscoelastic is there, so that I don't have to bother, go underneath the lens and a pupil to take it out. Time कम है क्या? Fast forward कर दूँ? हाँ? Time कम है?
Please, time.
So this is, every time you may not be lucky. So this was the patient, we tried to do this, and the pupil has started becoming smaller. And now when we do, I put on a viscoat, but now see what has happened. The iris has come into the phaco port. Iris is totally macerated. Iris is trying to collapse from the side port, where there will be natural chafing over there. So this is not a very good idea, that to keep on doing the phacoemulsification without putting the rings. So you can see that what has happened. So sometimes you can get away with it, but sometimes you may not. So it's better to use the devices. If the pupil size is less than 4.5 millimeter, it's always ideal to use something. So the Malugin ring is though a little expensive, but easiest to use because the scrolls go straight away onto the iris and there is not much of the manipulation. Fastest, you go, now first a scroll goes in, very simple, I am putting it on top of it. Then I slightly tilt like this to go on to the one side, then I slightly tilt the ring on the other side this way, 5-7 degree, and then engage straight away. And finally, we scroll the sub-incisional, just pull it and put it. So just done. This is real-time video without much editing on this. So this is fastest, but this being expensive, BHEX is a very good option. So, but this is a little soft and it can go from the side port, so we put it in. So it needs a little experience because they are all in the same plane. So when you are trying to put one hook, it may come out. So you got to slightly lift and keep it tilted. So and the forceps comes along with it when you order this ring. So I am trying to engage this end. You can see that I got to manipulate slightly because you're trying to go under the iris. I'm trying to lift it and put it over here. And now it has got engaged. Now I'll put on this one on this side. But you need 2 side port incision because it's not possible to go from one side port incision. The other side you will have to go from the. So normally I make 1 side port, but whenever I use the BHEX, I make the 2 side port incision. So I go there So
Sir,
hold
fast,
it.
please.
Huh? Fast.
Quickly, please, yes.
अभी 2 मिनट है ना? क्या कह रहे हो यार?
Sir, carry on if you can finish it fast because the other station is also waiting. There's one more speaker.
So
there
the
which-
B hex, okay. So B hex, the biggest advantage of the B hex is that you can just remove it, hydro explantation. You don't have to put on a viscoelastic. You can just pull it out from the side port. It comes out. So you don't have to use anything. So I'll just come to the. This was the one patient I tried to put the B hex, failed. Tried to put the Malugin, failed. Then ultimately went on to put the iris hook. So iris hook still holds very good. So I'm removing this Malugin ring was stuck over there, so will not go under the iris. So a 97 years old lady. So ultimately I went to put on an iris hook. So whenever we are putting the iris hook, normally when we make a side port incision for the phacoemulsification, we make corneal incision. But if you make a corneal incision, iris will get lifted and there will be chaffing. So whenever you do the incision for the iris hook, you are not putting anything. There is no danger of chemosis. Make your incision at the limbus so that the iris is not lifted up. So if you like, this you can see over here. So I'll take my incision backwards. So do not put corneal incision for phaco when you are putting some irrigation port. The fluid keeps on coming. If it's a limbal incision, there will be chemosis. But for this, even you can go to the sclera. It should be parallel to the iris, so there is no lift over there of the iris. You can see that this is over here. And another important thing is that the pupillary border has to go underneath the internal lip of the cornea. If it is in front of it, it will keep on rubbing. So one is that you make it a diamond shaped, but then this hook keeps on disturbing you. Normally we make a box. The box has got a disadvantage that the pupillary border gets lifted up, and when you are putting a phaco tip, it keeps on disturbing and keeps on damaging the iris. So I normally prefer to make a trapezoid incision. That means the first two incisions, which are side of the main port, are closer to each other so that the lift is less, and I can pull the iris underneath the incision line. So we come over here, bring it closer so that the internal border gets sucked in. So whenever there is still iris prolapse is happening, lower the bottle height, do the hypovolumic phaco, tighten the wound if it is leaky, make a fresh port if it is too much of a leak over there from the, if there is a premature entry or side port is leaking. Side ports you can always make fresh and small. Never push with the iris sponsor from the same port from where it is prolapsing. You will damage the iris. Go to form the another port to replace it. Thank you very much.
Thank you, Arbanj.
Now I call upon our Chief Instructor, Dr. Rajiv Chaudhary. He's a very eminent and a very fast surgeon and a high volume phacosurgeon from Indore. So welcome Dr. Rajiv Chaudhary. His topic is cataract surgery after any refractive surgery, the difficult management in such cases.
Thank you, Vijay. From the starting of the session, you've seen the good video and everything with the complicated, subluxated, hypermature, small page. This is more of a theoretical topic. It's a complete guide to cataract surgery after refractive surgery. Means we are facing LASIK and all that, and after that patient coming for the cataract surgery, what option we have? Requires meticulous planning. Especially challenging is the IOL power calculation, because there is a multiple time we have the errors in the power calculation. Previous refractive procedure can change the corneal profile, leading to challenges in measuring the eye optical power. And post-refractive surgery, patient may have irregular astigmatism, complicating the IOL selection. So intraocular IOL power calculation remains the most significant challenge. So it needs preoperative assessment. Refractive effect is related to corneal flattening, thinning, and several other evaluated this induced changes, overcome all patient expectation and visual outcome. So it required detailed history, understanding a type of refractive surgery, accurate biometry. This is one of the most important thing. Use of device like optical biometry, Scheimpflug imaging, and high quality keratometry helps in appropriate IOL selection. Especially the wavefront analysis helps evaluate high order aberration, remaining high order aberration. Aim to provide comprehensive guide for accurate IOL power calculation, right IOL selection, intraoperative management, and especially the patient education about their expectation. So accurate IOL power depends on corneal refractive power and axial length. Now axial length remains the same, but cornea is becoming oblate in myopic correction and prolate in hyperablation. Consequently, changes in the anterior chamber depth and axial length changes the posterior corneal curvature and troubling the calculation of the intraocular lens power to be implanted in cases of cataract surgery. So preoperative planning, it is crucial to address the high expectation. There is need to emphasize the significance of understanding the managing postoperative astigmatism, patient counseling, complete workup, and treating the dry eye, because sometimes most patients with the LASIK, they have come with the dry eye, MGD, and topography and A scan changes assess the corneal curvature and higher order aberration, impact visual function. Repeated topography and A scan measures are taken. This gives the valuable information, including the equivalent K reading map. Topography also enables corneal astigmatism regular or irregular when dealing with irregular astigmatism, compromise corneal optics to calculate the IOL power. First step entail topo-guided normalization and then calculation after 3-month period. In some cases where there is a corneal aberration is much more. Holiday 1, SRKT do excellent job in normal eye, but in post-refractive eyes they are inaccurate. Traditional IOL formula usually result in hyperopic surprises when applied to post-myopic correction, and in myopic surprises, one post-hyperopic correction done. So Dr. Hill and Shoy, that formula for those with prior refractive surgery is the Barrett-Drucke. Why there is a source of error? First and most importantly is the keratometric is the index error, because there is a change in the corneal curvature, and because of the change in posterior corneal curvature, and this leading to we got 7 minutes after our time. Okay? To calculate the dioptric focus power of the cornea, you need to know the both anterior and posterior. So you have to assess the depth of the anterior chamber and the corneal and change in the posterior corneal curvature. Let's give the formula. A new generation formula also utilizes the relationship between the steepness of the cornea and anterior chamber depth. After a myopic ablation, predict a falsely shallow anterior chamber depth and thus more anterior effective lens position. After hyperopic ablation, we can predict a false deeper effective lens position, resulting in an overestimated lens power with subsequent myopic surprise. So new techniques, what we can do, historical method, what if you know nowadays we keep all the records of the doing LASIK patient. So pre-LASIK or pre-refractive surgery, keratometric, anterior chamber depth or epi-length. So if you know that you can assess with this, you're taking into consideration this, combining with the post-refractive surgery spherical equivalent. Double K method means utilize pre-refractive surgery keratometry and what are the changes in the keratometric and calculating this. There is an ACRS online software available which give the predictable lens power. So IOL Master has a feature where we can select post-LASIK, post-PRK, post-RK in myopic or hyperopic mode. Barrett Uniscal 2 and Barrett 2K ACRS, and we usually prefer to do multiple formula in IOL power calculation and then select in between those. Aberrometry provide refractive information, including spherical and cylindrical. Higher order aberration are considered abnormal and can be cause of increasing glare and halos after multifocal IOL. This may need treatment. Intraoperative aberrometry can be used, but probably it is not routine in the practice. There is a multiple option. Preferable lens is most preferred, monofocal. Multifocal is advised to and usually when total higher order aberration to be less than 0.3 micron. EDOF IOL preferred due to lower chances of visual aberration. Teric IOL, we can use regular bow tie corneal astigmatism within central 3 mm. We can use toric. A difference of 0.75 in corneal astigmatism magnitude between two ocular biometer. In case of highly irregular astigmatism, it is best to plan monofocal, and patient may later plan go topo-guided PRK, whichever is suitable. So in rule in practice, never place a multifocal IOL with previously hyperopic LASIK. Also never place monofocal IOL with a negative spherical aberration profile in eye with previous hyperopic LASIK. If patient had a myopic LASIK and smooth topography without any irregular astigmatism, sometimes EDOF or multifocal can be used. If there is irregular astigmatism or significant irregular topography, avoid diffractive technology and gravitate toward either monofocal. Now, this is video of the RK because in other cases, surgical parameters, surgical techniques remain the same. So, this is a multiple eyes. When indoor, we have so many cases of RK. So, we come across more of the type of these cases than anybody. So, you have to select the right plane for the incision. It is not about the astigmatism. It is about the where the healthy cornea is available. So, we have to see side port because then sometimes this incision give away. So once you try to do the 1.8 or 2 mm, and the incision should be slightly posterior limbal so that you can avoid that end of the incision of the RK incision. So once micro incisional forceps, then you can remove this and put the intraocular lens. Another is the same with the femto you can do with the same removing. Again, the incision is the most important thing. You can select the site. So here the selection of the incision site is most important, taking into consideration post-limbal incision, low phaco, low bottle height, because they are the myopic patients, and we can. Then IOL master felt, okay, you have to use the keratometry different, and you can assess the level of operative concentration, and then use of the eye trace. In the post-operative eye trace, what happens, what it do? If there is a brulling and a change in the reflection, we thought of that there is a regression of the myopia. But if the DLI is less, it means it is a starting of the cataract, and you can directly go for the cataract surgery. So in short, enhanced monitoring, addressing, and careful consideration of corneal shape, visual expectation, advanced diagnostic tool, give a good surgical outcome in difficult situations like RK and LASIK patient. Thank you. Thank you.
Thank you, Dr. Chaudhary, sir, for enlightening the importance of finding out the true K in such cases.
Probably there is no time for. I thank you, my colleague speaker, Dr. Ashok Shroff, Dr. Nishlani, Dr. Rajesh Joshi, Harbans. Can you come for a group photo on the stage?